So today we're going to be talking about the spinal cord, spinal nerves, and the somatic reflexes. So we established last week that in the central nervous system, we have divided our nervous system structurally, and functionally. Functionally is physiologically, and structurally is anatomically. Okay, so structurally, we have the central nervous system, CNS, central nervous system. And you have the peripheral nervous system. The central nervous system is divided into the brain and the spinal cord. And the peripheral nervous system is comprised of all the nerves. And the nerves are divided into somatic. They are divided, actually, the nerves have two classifications. There is structural classification, structural, meaning they either somatic, meaning they deal with tough tissue, such as bone, skin, muscle, ligament, while soft tissue is known as a visceral tissue, like your heart, like your heart, lungs, bladder, kidneys, liver. So that's the structural classification. Functionally, the nerves, they are either dealing with input, that is sensory, and output, that is motor. Guys, this is really important. You got to know all of this. So we said that the nervous system is divided into this butterfly shape central nervous system for integration. So we integrate the information. There's integration. There's processing, integration, processing, integration, processing, and control. Integration, processing, and control. Integration, processing, and control. And that is your central nervous system, your CNS, central nervous system. And that is your brain and spinal cord. So your brain, your spinal cord are both preoccupied with integration, processing, and control. You make a phone call to the fire department, they're gonna process, there's fire in your house, you need the fire truck, where your house is, then they're gonna send an output. And they're gonna generate an output. They're gonna generate an output. But you make a phone call first. You make a phone call, and that is known as the input. You make an input phone call, they process it, they send an output. You call 911. You have fire, they're not going to send the police. You have fire, they're not going to send the ambulance. You have a medical crisis, they're not going to send the police, they're not going to send the fire department, they're going to send the ambulance. You have some crime, they're not going to send the ambulance or the fire department, they're going to send the police. Sometimes they need to send both. So that is processing. That is integration. That's the job of the control center, the integration center. So your central nervous system is right here, this part here, where you have your brain, your spinal cord for integration and processing. This whole part that is responsible for receiving input, generating output. Imagine you're trying to call 911, but the call is not getting through. They are there, they are in their offices, they are ready to send you whatever you need, the police or the fire department or the ambulance, but the call is not getting through. Are you gonna have an output? So these two lines, the input line and the output line, those are all known as what? I'm sorry? The mumbling. When I ask a question, it's just some mumbling. I need somebody to raise your hand and tell me one sentence. I will work with that. Give me some sentence, flour, I will add butter, I will add egg, I will try to make something out of it. No, the integrators are here. No, I already write it here. You cannot have two integrators. You cannot have two centers. One center for integration, processing, control, that's either your brain or your spinal cord. Then this other system, to get you to the input signal or get the output signal. What's that system called? PNS. That's why we have a central nervous system divided into brain and the spinal cord. You see? Brain and the spinal cord. The other one, as Michelle said, that is your PNS, peripheral nervous system. And PNS is not enough because on the exam I can say PNS stands for peripheral, and then you say, oh, it's PNS.
Yeah, peripheral.
Peripheral nervous system. Okay, we said that this peripheral nervous system is divided into an input and an output. This input is always connecting what? The receptor. The thermoreceptor for heat. The chemoreceptor for chemistry, tasting the blood. Is too acidic, the pH down. Too basic, pH is up. The glucose is high. Calcium is high. The potassium is low. That's chemoreceptor. You have for temperature, that's thermoreceptor. Then in addition, you have thermoreceptors, chemoreceptors. And you also have thermoreceptors, the chemoreceptors, chemoreceptors, and you have osmoreceptors, and then you have nocioreceptors, and you have mechanoreceptors. So these are the ones who are going to send an input that's sensory. So input is always why is input always sensory? Because you sense. You saw somebody dying, you call the ambulance. You heard somebody screaming, rape, assault, you call the police. Then you see fire, you feel heat, fire, you call the police. So input is always based on sensation. So the input is always sensory. And if the input is always sensory, the output is always motor. And the output is always to do an effect. It's always to do an effect because it targets the effector. The effector. So the effector is the cop. He's going to come do the effect. The ambulance, they are the effector. They're gonna come do the effect. The fire department is gonna come do the effect. So that is your effector. In your body, the effector is a gland. When too much sugar, the effector is the pancreas. It's gonna squeeze, secrete a lot of insulin. The liver is gonna squeeze glucose. The muscle, you touch something hot, the heat is gonna go up into your spinal cord and brain. The output, withdraw your muscle. Your muscle is gonna contract to flex away from that really burning sensation. So the output is always motor and is always effector. And we call that efferent based on effector. Efferent. That's efferent neuron. While up here you have afferent. Afferent. So an input is always sensory and afferent. And an output is always motor and efferent. The last thing. So now we divided the nerves based on function. Function is motor versus sensory, input versus output, carrying an input signal into the inside of the control center. And these are coming out, output. But there's another classification, somatic versus visceral. So if you're dealing with a loop involving soft tissue, you have two kinds of tissues. It's either your muscle and joint feeling pain, that's tough tissue, that's somatic. Or your heart is feeling pain, your lungs are feeling pain, your bladder is feeling pain, that's visceral. That's the only difference. The loop is the same, the template is the same. The only difference is what kind of tissue am I dealing with. I'm dealing with soft tissue, then that becomes input, sensory, afferent, visceral. And this becomes output, motor, efferent, visceral. And if I'm dealing with tough tissue, then that has to change. It becomes input, sensory, afferent, somatic. Somatic is for tough tissue. Somatic is for tough tissue, like the bone, the skin, the muscle, ligament. Soft tissue is the visceral, heat, lungs, bladder. You gotta know somatic versus visceral. Somatic versus visceral. So what are the functions of my spinal cord? So now we're gonna learn about the spinal cord. That's one of the computers. The first lecture is about this, spinal. The second lecture is about that, the brain. So we're gonna study it, each one as a central nervous system and all the input that's coming into it and the output that's getting out of it. So the functions of your very important spinal cord is for conduction. They have nerve fibers. What are nerves? Nerves are bundles of axons. When you wrap axons together and you stack them up, that is known as a nerve fiber. So the nerve fibers conduct sensory and motor information up and down the spinal cord. There is neural integration. What is neural integration? Neural integration is when the spinal neurons receive input from multiple sources. So they integrate this input and they execute the appropriate output. For example, bladder control. You have also the important function within your spinal cord, and that is for locomotion, the ability to move and localize from one place to another. And these are groups of neurons that coordinate repetitive sequences of contractions for walking. And lastly, you're not a control center, being the spinal cord, unless you're able to elicit a reflex. When they strike that tendon with that plastic hammer, you see there's an involuntary knee-jerk reflex. That is caused by your control center because a sensory input sends by mechanoreceptors. You see, we have them here, mechanoreceptors. They detect mechanical change, and that causes an integration that elicits an output to withdraw your foot away. The spinal cord is a cylinder of nerve tissues that arises from the brainstem at the foramen magnum of the skull. This foramen magnum is very important. It's a bony prominence, like a hole, and through it, your spinal cord will start to come out. It's very important to know your foramen magnum. This foramen magnum is very important because it is the outlet, the bony hole in your skull as a bone through which your spinal cord is going to come out. This is very important, guys. In your brain, you have something known as the brainstem that is comprised of the midbrain. Number one is your midbrain. Number two is your pons. Number two is the pons. And number three is the medulla oblongata. And lastly, you have the spinal cord coming out. The hole here, that's your skull. Up here is your skull. And down here is your vertebral column. And in between the hole, the outlet through which your spinal cord is going to come out, that is known as the foramen magnum. You really need to know this. That's going to be on your exam. It's called magnum, meaning so big. Foramen is a hole. It's the hole in your skull through which your spinal cord is going to come out. The spinal cord is divided into regions. There's a cervical region, that's the top region, that is right below your skull and the beginning of the vertebral column. That is known as the cervical region. Right below it is your thoracic region. And below the thoracic region is the lumbar region, and lastly, the sacral. So now, if you look at your vertebral column, you have frontal bone, right behind it, frontal lobe. You have parietal bone, right beneath it, parietal lobe. You have occipital bone, right beneath it, occipital lobe. On the side, you have your temporal bones, and right attached to them is your temporal lobe. So the same thing, you have your cervical vertebra, inside it, cervical spinal cord. In the middle, you have thoracic vertebra, inside it is your thoracic spinal cord. Then below, lumbar vertebra, lumbar spinal cord, and in the end, you have your sacral region. Something very special is that when you look at the spinal cord has a cervical region, it has a thoracic region, it has a thoracic region, and lastly, you have your lumbar region, and lastly, you have your sacrum. What you're going to see is the same way our bones protect our brain, the vertebra is protecting the spinal cord. So you know you have a case, a safe to protect the money and the jewelry. So your brain is more valuable than all the money and all the jewelry. So you need to protect it. So you protect it with the bones of your skull. And your spinal cord is protected with the vertebral column bones. So if you look at the cervical spinal cord, it is full of the cervical vertebra. It has spinal cord, thoracic vertebra, spinal cord, lumbar vertebra, spinal cord. But then at lumbar 1, spinal cord stops. The rest is empty. There's no spinal cord down here. That's why they do the epidural and the spinal tap. But is this empty? Nothing else here. Just air. Just air inside here. No. There's nerves. Nerves like that. Coming in and getting out. But no computers. No cell bodies. These are all somas. Cell bodies. Nuclei. Important for integration. Important for processing of information. But once you go below, for children, it goes up to L3. The spinal cord goes down to L3. But when you're an adult, it goes up to L1 and then it stops. And the rest are nerves. These nerves coming down like a tail is known as the tail of a horse. Known as the coda equina. The coda equina. The coda equina. The inferior point of the spinal cord, where the spinal cord ends, is known as the conus medullaris. So you see, this is my coda equina. You see the tails coming down, and my spinal cord stops here at this cona medullaris, or the medullary cone. What's the difference between the medullary cone or the conus medullaris and the coda equina? Excellent. And the coda equina is? Yeah, bundle of nerves are coming down. Excellent. Okay, so that's your spinal cord, and you see the ribs. These are your vertebral column. These are the vertebral ribs, and that's the spinal nerve rootlets, and there's a posterior root ganglia. You see? That's your spinal cord, and these are the nerves coming in. These are the nerves coming in. See? These are the nerves coming in, bringing information. And these are nerves coming out, carrying information away from both sides. Then the meninges, these are fibrous membranes that enclose the brain and the spinal cord. They separate soft tissue of the central nervous system from the bones of the cranium and the vertebral canal. So from superficial to deep, you have the dura mater, then the arachnoid mater, as in the middle, then the pia mater. The dura mater is the strongest. That's why they call it the rough mother. It's periosteal tissue. It's very strong, and it has porous bone known as the spongy bone. So that's the thickest, strongest layer. That is your dura mater. Then you have this holes here. This is spongy bone, spongy bones. And this spongy bone is your periosteum. So that's the dura mater on the outside. Then you have the arachnoid mater. The arachnoid mater is a layer that is right below the dura mater, and it looks like a spider. So that's known as the arachnoid mater. Below the arachnoid mater, you have your pia or pia mater, and that is the softest. That is the softest tissue that is intimate and touching your spinal cord. So there are capsules around your spinal cord, protecting it from damage, protecting the spinal cord from trauma. And these layers or one is a soft layer followed by arachnoid matter, and then lastly you have your dura mater. So you see this butterfly shape. You see the butterfly? This butterfly shape, that is your spinal cord. So the spinal cord is cut in half. So one region is in the back, that's known as the posterior, and we say posterior and we say dorsal. The same thing. Posterior, dorsal, and anterior is also known as ventral. So posterior is in the back, ventral is in the front. So from this diagram here, when you see posterior in the back and anterior in the front, what does that tell you about the posterior horn and the anterior horn? Yes, so the posterior horn is responsible for receiving input that's sensory afferent, while the anterior ventral horn is responsible for efferent motor output. That's very important for you to know that the posterior dorsal horn is responsible for receiving, because you see the arrow point here. So that's the back. So on the back, we receive posterior dorsal input, while in the front, we send out anterior ventral output. Clear? So a patient, if you have two patients, one has damage to the posterior dorsal horn, patient number one, and patient number two has damage to the anterior horn. What do you think the symptoms will be like? If patient number one, damage to posterior. Patient number two, posterior spine, damage to anterior. Patient number one has damage posterior, anterior spine, and patient number two has damage to anterior posterior spine. How are the symptoms gonna be different?
So they will have problems receiving info.
You're exactly correct. They have a problem sensing, but they have no problem generating an output. But these guys, these are the most trouble. That is what's known as Lou Gehrig's disease. In Lou Gehrig's disease, also known as ALS, amyotrophic lateral sclerosis. So there's damage here in the front. So that means they cannot have a motor output. They have intact sensation. They understand everything. They have emotion. They have ideas. They cannot get them out. Because the problem, sensory is fine. It is the output. They cannot communicate. They cannot get out their ideas. So that's really frustrating. You have something to say, you're unable to say it. You have some ideas to say, you cannot communicate them to the people. So the people believe that these people, because they cannot communicate their ideas, they have no ideas. They have no emotion. And that is what's really distressing to the patients more than the disease itself. It's the false stereotype that these people, because they cannot communicate ideas, they cannot communicate emotion, then they have no emotion to say. Oh, that patient has autism. Treat them really badly. You know, they don't feel anything. They don't care. No, they care. They just cannot respond. So Lou Gehrig's disease or amyotrophic is lateral sclerosis. So sclerosis is scarring and fibrosis. Scarring and fibrosis. The spinal cord has gray matter and white matter. Gray matter is different from white matter because white matter is due to the myelin sheath. This myelin sheath is like carpet saran wrap. You know the saran wrap around the axons. We talked about this last week, that around the axons you have saran wrap that's going to like increase the conduction speed. But the gray matter, so gray matter is always the center. The central nervous system is gray matter, while the peripheral nervous system is full of white matter, because you need white matter here. You need white matter here so they can speed up the communication through these nodes. These are nodes. So through these nodes, you jump up. These are known as the nodes of Ranvier. That's what's going to make the conduction speed really fast. We said last week that the axon conducts as rapidly as it is myelinated. So the more myelinated an axon is, and the more wide or small the axon is, do we get a faster speed. So the more wide, the more myelinated you are, the faster. But you don't need myelination in the center. So normally the natural color of our neuron is gray. That's why it's called gray matter. But when the gray part of your neuron has a lot of myelin saran wrap around it, it's going to make it look like pearly color, white color. So these are we have two posterior horns that receive, you see the two horns? Horn number 1 and horn number 2. And two anterior horns, horn number 1, horn number 2. What do they both do? They receive sensory nerve fibers that synapse with interneurons in the horn. And two anterior ventral horn that contain the cell bodies of the motor neurons. So you see your two horns? That's your posterior horn. That is your anterior horn. And I guarantee you, you need to know that. You need to know which one is responsible for receiving sensory input and which one is responsible for generating sensory output. So for spinal tap or lumbar puncture, we always target between L3 and L4 because there's no what between L3 and L4? There's no spinal cord, just coda equina. Now we are talking business. You see, when you're going into carrying input, are you ascending or descending? When you're going to no, you're sending input. You're sending input. That makes you ascending. You step on glass, that's ascending. To send the output, remove foot from glass, that's descending. Send an output to remove finger from fire, that's descending. So you have to know that. Descending tracks always carry sensory afferent input, while ascending tracks always receive input, sensory afferent, that's ascending. And this is descending. Descending is to send out efferent motor output. Descending. Decussation represents the crossing of the midline that occurs in many tracks so that the brain senses and controls contralateral side of the body. So decussation is when you cross. So that's why some people, they have, God forbid, trauma or stroke on the left side, they cannot move the right side of the body. Or they have a trauma on the right side, they cannot move the left side of the body. So that's a big problem. But what does that signify? That signifies we have two kinds of tracts. We have ipsilateral, where some regions on the left, they control some regions on the right. And some regions on the left, they control some regions on the left. And some regions on the right, they control some regions on the right. And sometimes you have some regions on the left cross to control some regions on the right, and some regions on the right cross and control some regions on the left. So contralateral control, and there's ipsilateral control. Contralateral control is only achieved when we have decussation. See that word decussation? What is decussation? Decussation is when you cross. So it's not like always the right side controls right side, and the right side and the left side controls the left side. Sometimes the right side is going to cross and control some parts of the left side, and sometimes the left side is going to cross and control some parts of the right side. The ability to cross to the other side is known as decussation. Decussation. And the ability to control the same side, that's known as ipsilateral. And the ability to control the opposite side, that is known as contralateral. Everybody now know ascending versus descending versus decussation versus contralateral versus ipsilateral. Yes?
That's the crossing of the signal.
The crossing of the nerve carrying the signal. You know the subway. You know there's no line between Brooklyn and Queens. You gotta come to Manhattan. You cannot go from Queens to Brooklyn unless you have a car. But if you're taking a subway, you gotta come through Manhattan, then go back into it. So that's decussation. But if they make that one line directly linking Brooklyn to Queens, as Mayor Adams said, he said he's gonna do that one. Let's see if he's gonna do it. Make my life easier. But that's what he said he's gonna do. Then he's gonna make ipsilateral. So you have nothing to do with Manhattan no more. It's gonna save a lot of time. So this thing is, if you're going to a different region when you cross, because you are on the left side, you're supposed to control the left side. But you have some nerve, you have a whole subway line, subway track. That's why we call them ascending tracks. Because there's so many nerves, so many bundles of axons that are tied together. So they make a track. So the information flows through them, like in the subway track. So some tracks, I'm not saying every single nerve track has to cross. No, some cross, some don't. So that's why you see some patients with stroke, they lose the left side. The stroke is on the left side, they lose some left side control. Some of them have stroke on the left side, they lose the right side. Because now that shows you have hit a nerve that decussate if you go to the other side. But if it's on the ipsilateral, the nerve did not decussate. Okay? Okay. These ascending tracks. You know the ascending track, can I erase that? Did everybody get that? This is so important. Did everybody get that? Okay. So let me write it on that other side. Now we said that ascending track, we also agreed that ascending track, we are trying to get to the brain. In ascending tracks, we gotta go to the brain regions, the brain center. There is a center for vision. There is a center for hearing. There is a center for emotion. There is a center for whatever. There's many different centers. 1, 2, 3, 4, thousands of centers. Now, this ascending information, we know that first we gotta go into our butterfly. We gotta go to the posterior And we have to, so first, our ascending track does not look like that. One line, one trip to the brain, ascending track. Sometimes a trip, you take one trip from New York all the way to California. That's not the case here. You got to stop Connecticut. You got to stop Wyoming. Then you go, California. So we cut up our movement into 3 different trips. You have a first order neuron. First order neuron. Then you have a second order neuron. Then you have a third order neuron. But both of them are pointing to the top. Okay? Now, they're telling you right there, look, the first order neuron detects stimulus from my receptor. So that's my receptor carrying sensory stimulus, obviously. That's the input. That's what else? Afferent. It could be thermoreceptor, chemoreceptor, nociceptor, osmoreceptor, mechanoreceptor. But the first order neuron is going to take the stimulus and transmit it to the spinal cord. So if you're going to get to here, if you're going to go from the receptor, where there's a stimulus, and you're going to go to the butterfly, your spinal cord, or your brain stem, that's the first order neuron. If you go from the spinal cord and the brain up into the thalamus, which is a region in the brain, the thalamus, that makes you a second order neuron. Look, second order neuron continues from the first order neuron to the thalamus. Then if you go from the thalamus up to the brain where you need to be, that's a third order neuron. So now you see the ascending track is not a one track. You got to stop at Times Square, take the second order neuron. You got to stop at the 59th Street, take another one that's going to take you to where you need to be. So we divide the ascending track into 3 steps. This is so important. Sensory track, sensory input, afferent, targeting the brain, divided into 3 neurons. And the 3 neurons are the first order neuron, second order neuron, and the third order neuron. Now look at this name. What kind of name is that? Spinothalamic. From the name, what kind of track is that? Spinothalamic. Is that ascending or descending? Look at the name. Spinothalamic. Spinothalamic. So that's ascending or descending? Ascending, because from the spinal cord to the thalamus. Spinothalamic, going up. There's also, that's the one track. So you have one track that, look, what does it carry? It carries signals for pain, pressure, temperature, light touch, tickle, itch. All of that is carried by your spinothalamic. When you eat, don't fill your stomach up. That's not good. Always eat a little bit. Very bad. Very bad, professor. Okay. Carries the signals for pain, pressure, temperature, light touch, tickle, and itch. The track is composed of axons of second order neurons. So the first order neurons end in the posterior horn. We know that. That's no longer a secret. We know that one. The second order neurons start in the posterior horn, then they decussate and form the spinothalamic tract. There are third order neurons. These third order neurons continue from there to the cerebral cortex. They continue from there to the cerebral cortex. And due to a cross of the second order neurons, there are signals that are sent to the cerebral hemisphere that is contralateral to the site of the stimulus. There we go. You guys see now? That's our spinal cord. Then we go up here into the medulla. And then, do you see the decussation? Did we decussate or not? Here. We began here. Then did we decussate here or not? We decussated. But what about here? Did we decussate here? No, we went straight all the way up. Decussation always happens in the medulla. So this patient, if they got a stroke here, they cannot control the right side. But this patient, if they got a stroke here, they cannot control the left side because there's no decussation. That's the medial lemniscus. Now look at this, spinal-reticular tract. That is the tract that is gonna, you know the name, reticular, spinal, that's the spinal cord. Reticular, what does reticular mean? Spinal reticular. It means the reticular formation, the spinal cord and the reticular form. What is the reticular formation? In your brain. So from the spinal cord to the brain, spinal reticular. Spinal thalamic. Where is the thalamus? Where? In the brain. So that's ascending. Reticular formation, where is it? The brain also. Spinocerebellar. Spinocerebellar. The spinocerebellar tract is a tract that is from the spine to the cerebellum. So is that ascending or descending? I'm sorry? Ascending. Very good. Now let's look at descending tracts. Descending tracts, they're not three, they're only two. So descending tracts, what do we know about them up to now, this point? Obviously, they descend from the brain center, center number 1, center number 2, center number 3, center number 4, center number 5. They descend from the brain, and this is the point where you have your first order neuron, and this is the second order neuron. This is the second order neuron. Targeting the effector, right? Because we target the effector. Now we're carrying a motor output. What is in ascending? We have sensory. In descending, we gotta have. What do we have in descending? We have motor, afferent or if. You gotta say all of them. We have motor, output or input, output, sensory or motor, afferent or efferent, efferent. The last thing now, visceral, somatic, we don't know from now. But you know it's there. You got to tell that fourth one too. Soft tissue, visceral, output, motor, efferent. Soft tissue, somatic, output, motor, efferent. So you got to know all four and how to assemble them properly. Now let's look at the upper motor neuron. Originates in the cerebral cortex or the brainstem and terminate on a lower motor neuron. And then the lower motor neuron is a cell, it has a cell body in the brainstem or the spinal cord, and the axon is leading to the effector. So the cell body of the upper motor neuron is in the brain, and the cell body of the motor neuron is either in the brainstem or in the cerebral cortex. Is lateral and anterior corticospinal tract. They carry signals from the cerebral cortex for precise, finely coordinated movement. Pyramids, these are ridges on the anterior surface of the medulla formed by fibers. So there we go. Do you guys see the descending pathways? That's the descending pathway. Which one decussate, which one does not? It's very important for you to develop that skill, to tell which one decussates, which one doesn't. This track here, corticospinal, it did not begin, it is not spinothalamic, it is not spino-reticular, so that is not ascending, that's descending. So which of these two tracks decussate? Does the lateral corticospinal tract decussate, or does the anterior corticospinal tract decussate? What's the name of the tract that decussate between these two tracts that are labeled in bold here? It has a name. What's the name of the tract that decussate between these two tracts here? Nope. Which one decussates? What's the name of the tract that decussates? Read it for me. It's in front of you. What's the name of the tract that decussates? I'm sorry? Excellent. You see, there's two of them. The lateral corticospinal tract. It's telling you here, decussation in the medulla, especially at the pyramid. The pyramid is the side where we have the decussation. So you see the decussation, who's passing and decussating through the pyramid? That is your lateral corticospinal tract. Then when you go down, you're not decussating, you're going ipsilaterally, that is your anterior corticospinal tract. There we go, showed it to you better now. You see the lateral corticospinal tract decussates right here. You see the medullary pyramid? And you see here, that is your, what is that? That is your anterior corticospinal tract. Okay, then we have more descending tracts. There's the tectospinal tract. The tectospinal tract begins from the midbrain, the tectum. But the point is, we have descending. These are descending from the tectum, the tectospinal tract. Then there's a lateral and medial reticulospinal. Now the name, reticular. Where do we say the reticular formation is at? In the brain. So reticulospinal, is that ascending or descending? What about vestibulospinal? So the vestibular nucleus is in the brain. So is that a form of ascending or descending? That's a form of descending. That's what we talked about. Poliomyelitis and amyotrophic lateral sclerosis. Now, if you look at amyotrophic lateral sclerosis, you see that poliomyelitis, itis means inflammation. Polio is the poliovirus. It's when the poliovirus causes inflammation of the myelin sheath of your nerves. It destroys the motor neurons in the brainstem and the interior horn of the spinal cord. Signs of the polio include muscle pain, weakness, and loss of some reflexes. They are followed by paralysis, muscular atrophy, and respiratory arrest. The virus spreads by fecal contamination of water. Amyotrophic lateral sclerosis, or Lou Gehrig's disease, that shows destruction of the motor neurons and muscular atrophy due to scarring of lateral regions of the spinal cord. Astrocytes fail to reabsorb the neurotransmitter glutamate. So you see, a nerve is a cord-like organ composed of numerous nerve fibers, axons, that are bound together by connective tissue. Smaller branches are called peripheral nerves. So there are disorders of these nerves known as peripheral neuropathy. We have some sensory nerves, we have some motor nerves, and we have some mixed nerves. The ganglion are a cluster of nerve cell bodies outside the central nervous system. So we have 8 cervical spinal nerves, we have 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, 1 coccygeal. 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, 1 coccygeal. Each spinal nerve is formed from 2 roots, proximal branches. There's the dorsal root and there's the anterior ventral root. See your spinal cord, that is your ventral body, and that is your spinous process. And inside it, you have your spinal cord. You see? That's the spinal cord. Now, what is shingles? Shingles is a common disease of early childhood caused by the varicella-zoster virus. It produces itchy rash that clears up without complications. So the virus remains for life in the posterior root ganglia and is kept in check by the immune system. The shingles, known as the herpes zoster. So what's the difference between chickenpox and shingles? Both of them are caused by zoster, but chickenpox is caused by varicella zoster. You know, with the C letter. Chicken has a C in it, varicella has a C. So that's a form of very dangerous disease that where the virus remains for life in the anterior or the posterior ganglia. In the posterior, meaning that it will affect what? Sensory or motor output. Yes. Now, shingles is localized disease caused by the virus traveling down the axons, the sensory nerves by fast axonal transport when the immune system is compromised. So there's a painful trail of skin discoloration and fluid-filled vesicles along the path of the nerve, usually on chest and waist on one side of the body. There's pain and itching.
Shingle
That's shingles. So in shingles, there's a transport where, you know, these axons, there's like axonal transport. So your this virus is gonna hijack the subway and it's gonna start to move in this axonal transport. There's childhood chickenpox vaccinations that reduce the risk of shingles later in life. That's shingles. You have multiple nerve plexus. These are meshworks. These are networks of nerves. You have your cervical plexus in the neck, and it supplies the neck and the phrenic nerves to the diaphragm. There's a brachial plexus that is near the shoulder on C5 to T1. It supplies the upper limb and some of the shoulders and the neck. There is a lumbar plexus in the lower part, L1 or L4. It supplies the abdominal wall, the interior thigh, and the genitalia. There is a sacral plexus. Sacral plexus, in the plexus, you'd have L4, L5, and S1 to S4. They supply the remainder of the lower trunk and the lower limb, including the sciatic nerve. So these nerves have both somatosensory and motor functions. So the somatosensory function carry sensory signals from the bones, the joints, the muscles, and the skin. So they carry sensation for touch, heat, cold, stretch, pressure, and pain. It provides proprioception, and the brain receives information about the body position and movement from the nerve endings in the muscle, the tendons, and the joints. So the motor function is primarily to stimulate muscle contraction. So that's your cervical plexus. You see it's right below the neck. That is your right on the neck, actually. That's your cervical plexus. And that's your brachial plexus in the arm, in the axilla. And this is the cutaneous innervation of the hand by nerves from the brachial plexus. This is the lumbar plexus. See, that's the lumbar plexus. And there's a sacral and coccygeal plexuses. So radial nerve injury. Radial nerve injury, these are just showing you what happens to the nerves that are coming out of these plexus. When they're harmed, you would have, with radial nerve injury, you would get a wrist drop. With sciatic nerve injury, you would get sciatica. Sciatica is caused by this herniated disc. And you can cure sciatica. In sciatica, you have to get, the fat from the sheep. You cut that, you put it you dissolve it in the fire, you put it in the, what do you call the thing? You dissolve and you put it so hot, then it melts like oil. Then in the morning when you wake up, before you eat nothing, before you brush your teeth, yeah. I mean you can brush your teeth. I'm just saying how early that is supposed to be. You brush your teeth, then nothing else. Nothing else. The first thing enters your body. You sip it, that fat is gonna go and restore that herniation. But what kind of sheep?
Yeah, where to get it from?
Yeah, that's gonna cost you. That's the sheep of the Sahara of the Arabia. You gotta go all the Arab Sahara. Yeah, because the grass they eat is not here. The, this is scientifically proven. It's proven for me. If you have it and you try, it will restore it. It will try. You're not gonna lose.
Well, I want to get that thing, you want to have that done like here, where you could get it done here, huh? So, and stretching, basically stretching.
Because you have to go to the Sahara. There's no Sahara here. Because the grass of the Sahara is different. So the sheep here, they eat grass from the farm. That's not good. It's the one in the hot Sahara that makes their oil very good to repair that herniated disc. So if you have sciatica, you want to cure that one. Yeah, so your vertebral column is squeezing onto this spinal cord, and this spinal cord is, and the nerve is pinching and touching the spinal cord. So the nerve is touching your spinal cord. I don't call it the vein, but it's full of sensory nerves. So that's the sciatica.
Stretching and all that.
It's gonna, no, it works a lot. It relaxes the nerve. Actually, yes. Obesity, like if you are suffering from obesity, if you don't exercise a lot, that's all gonna make worse. But if you rest and you do some particular exercises, you can even find it on YouTube. You don't even need to go to the physical therapist. You go, they will, or maybe go to the physical therapy. They're gonna massage it in a way that's gonna, trust me, relax. It makes a lot. The dermatome is a specific area of the skin that conveys sensory input to the spinal nerve. So there is a dermatome map where this is all sensation. So that's why when one nerve is injured, the other nerve, because they share the same region. These are known as the dermatome. So reflexes, you have somatic reflexes and visceral reflexes. So look at it, that's a perfect example of a reflex. So what do we begin with? Number one, a receptor in the muscle near the tendon. You strike that, that's going to cause an afferent sensory nerve fiber that's going to go into your spinal cord, carrying sensory afferent input, and then the spinal cord is going to synapse. You got a synapse. There's a synapse between between the sensory neuron and the motor efferent neuron, and that's gonna go to the effector. The effector here is not your tendon. The effector here is your quadriceps femoris. There are proprioceptors. These sense the stretch. The proprioceptors sense the stretch, and they sense the mechanical sensation. And you see these fibers, the intrafusal and extrafusal fibers, they are responsible for relaying that information. But the stretch reflex is important because it shows you, look at what happens in the patella. So you tap on the patellar ligament would excite nerve endings of the muscle spindle and the quadriceps femoris. Then the stretch signal travels to the spinal cord via the primary afferent fiber and the dorsal root. The primary afferent neuron stimulates the alpha motor neuron in the spinal cord. Then the efferent signals in the alpha motor neuron fiber would stimulate the quadriceps to contract, producing the knee-jerk reflex. At the same time, you have a branch of the afferent nerve would inhibit the opposing muscles from interfering with that knee-jerk reflex. So you see the hamstring contraction is inhibited, so hamstrings, or known as the knee flexors, do not antagonize the quadriceps. So that's very important to know. So here when you step on glass, stepping on glass stimulates pain receptors in the right foot. Then there is sensory neuron that activates multiple interneurons. Then there's ipsilateral motor neurons to the flexor are excited. So that's when we're dealing with ipsilateral stimulation of that muscle. But contralaterally, you have motor neurons to the extensor. So we stimulate the flexor for contraction. And we also send contralateral motor neurons to the extensor. We excite them, and that's going to cause the extensors to be excited. And that's gonna help you maintain balance. This is amazing. Okay, and this is the nerve fiber. These are the tendon fibers, and these are the bundles. Okay. Spinal cord trauma can come either as paraplegia, where you have complete paralysis of both lower limbs, and quadriplegia is the paralysis of all four limbs, and hemiplegia is paralysis of one side of the body. That's hemiplegia. Any questions? Let's take a break and